title of this talk is an algorithm for the selection of supportive elements in ankle-foot orthoses. And I'd just like to say a minute about where this came from. I've been practicing for a little more than 20 years. And over the course of that time, much of the time was spent at the University of Michigan in pediatric orthotics. Slightly later in my career, I was also an instructor at Eastern Michigan University, and a lot of what's in here evolved over time in my own practice, but also in an effort to explain the approach to orthotic design to the students. And so that was the genesis of this program. I'm now with Becker Orthopedic, and I'm the Vice President of Services there and the CTO. My work at Becker has actually involved areas which have extended this work, and the next talk on the 25th will be a little bit more about that. I should say also that with regard to the utilization of this content, a couple of years ago I visited Don Bosco University, and Andrea and Monica there hosted Rosie Hoganet and myself for a week in order to present this approach to orthotic design, and they have implemented some of this as a means to assist in instruction in laboratory courses, and so it seems to have some utility. So I want to talk a little bit about it today, getting into the assumptions that the algorithm is based upon. Of course, every methodology has to be based on certain fundamental principles. With regard to orthotics, of course, we have a growing body of evidence, but we still don't have a lot of research that demonstrates efficacy of certain approaches to orthotic practice. That evidence base is growing, but what we do have is a lot of fundamental knowledge, of course, about engineering and biomechanics and those types of things. And so the algorithm is based upon a lot of the evidence which would underlie the approach to orthotic design from that perspective. So with regard to that, the assumptions that the algorithm is based on are as follows. AFOs may change forces on anatomic structures and also joint alignment. I think that's pretty well documented in the literature. AFOs may directly influence joints they encompass, but they may also indirectly influence knee, hip, and trunk. And I think that also is fairly well established. It's actually been demonstrated in some of our own research and collaborative research through the past few years as well. AFOs contribute or are the attributes that provide this mechanical influence that AFOs can apply to the limb. This is a little bit of an outlier, but with respect to orthotic design, I think it's really essential to understand what attributes within the orthotic design provide that mechanical influence. And so for the purpose here, those attributes are defined by these three: AFO shape with respect to the shape of the weight-bearing limb, the AFO structural stiffness, and the compressibility of the orthosis materials that line the orthosis, in addition to the body tissues, those three things. So those three attributes are the main mechanical influences that we assume are involved in the orthotic design. It's also something that is becoming increasingly clear that AFOs evoke a coordinated or uncoordinated neuromotor response by virtue of the way they position the limb, by virtue of the way that they resist ankle motion or are positioned, and the amount of range of motion that is also allowed to occur. With regard to this approach to AFO design, the AFO may be represented in this algorithm. We're going to represent the AFO by a set of discrete supportive elements. We call those supportive elements within the orthotic contour. And this may be certain sections of the orthosis acting together. They're probably more commonly known as three-point pressure systems, but we want to think of these contours within the orthotic device as discrete elements, even though we know that they're interrelated and blended together. The sets of these supportive elements may have greater or lesser direct or indirect influence over the forces on anatomic structures and over the joint alignment. And so the direct influence, of course, is within the bounds of the AFO through three-point pressure systems. The indirect influence would be biomechanically coupled up the kinetic chain. And it's possible to associate, there's an assumption, it's possible to associate each of these supportive elements with an observed clinical indicator, whether it be an objective indicator like a position or a movement in observational gait analysis, or a subjective indicator, which would be patient feedback, comfort, feeling of stability, instability. But these can associate with these observed clinical indicators to determine the AFO design. So the algorithm will be applied by these 5 steps. First, to identify a postural abnormality if it exists, or a pathologic strain that is the intent to be treated with the design, and to associate that as being due to a posture, pronated or supinated, with regard to the foot posture index or other assessment. Now, this may be an abnormal excessive pronation or supination, or something which is just a posture which is tended toward which is providing the pathologic strain. Second, to assess the contribution of the hindfoot, midfoot, and forefoot to that postural abnormality through what's called planal dominance. Some of these concepts come from podiatry, by the way, for the pathologic strain. Then to select the supportive elements that may have the greatest direct and indirect influence over the principal biomechanical deficits. Fourth would be to prioritize the function from proximal to distal and select elements from forefoot to hindfoot. I'll speak more about this later, but the general notion here is that in general, we think that biomechanical function is most often prioritized from proximal distal. If you think of this in the sense that treating orthotically a patient who has weak hip flexors or weak control over the hip is and can be much more difficult than treating a patient who has a dorsiflexor insufficiency. So as you move up the kinetic chain, the severity of the deficit can become more profound. And so sometimes we try to gain advantage over more proximal prioritized function by sacrificing, in a sense, position or range of motion in more distal function in order to gain that advantage. And lastly, to balance the support between the supportive elements to achieve the desired outcome and improve comfort. And I'll talk more about that later as well. So one of the tools that we would like to use here is called the Foot Posture Index. This was developed by Anthony Redmond, a podiatrist, back in, I believe, 1998. And this is a clinical tool, that a validated instrument that was useful to determine whether a foot is pronated or supinated. And basically, you look at six attributes of the foot in weight bearing, and you score it. And if the score is positive, it's a pronated foot. If the score is negative, it's a supinated foot. And if it's 0, then it's a neutral foot. And each one of these attributes is scored, and then the total score can give an indication of the severity of the postural abnormality if it exists. So the 6 are talar head palpation, and that's basically if you think about sensing or detecting by palpation subtalar neutral, where you pinch the medial and the lateral sides of the tailonnavicular joint, and you look for congruity between the navicular on the head of the talus. That's basically what this is detecting here. And for example, in this first one, if the talar head is palpable laterally or medially, then that gives an indication of internal external rotation of the talus, which is consistent with the degree or 1 degree of pronation. Second, supra and infralateral malleolar curve, and that's the shape of the ankle looking from the posterior aspect of the leg and weight bearing, the shape of the ankle proximal and distal to the lateral malleolus. Calcaneal frontal plane position, which is basically is the calcaneus and varus valgus, and what's the degree. And then the prominence of the region of the tailonnavicular joint. So if you look at on the medial foot, the tailnavicular joint on the skin, and look for a concavity and convexity. That's what number 4 means. Congruence of the medial longitudinal arch has to do with the shape of the medial longitudinal arch and weight bearing. Relatively high arch would be associated with a supinated foot, and the depressed arch, of course, closer to the floor would be consistent with a pronated foot. And then there's the abduction and adduction of the forefoot on the rear foot, and that is the toe sign from the posterior aspect of the patient. So these 6 measures are useful in not only coming up with a composite measure of pronation of different types, because there are different types of pronation, but also on the severity of that pronation. We can use that clinically in order to determine not only the severity of the pronation, but where that pronation may be coming from. Another concept that this algorithm makes use of is a concept called planal dominance, which was written about. He had a publication, Donald Green, who's also a podiatrist, and that has to do with the influence of the orientation of the subtalar and the mid-tarsal joints on the components of pronation. So when we think about the components of pronation, we think of hindfoot valgus, medial longitudinal arch depression, plantar flexion of the talus and the navicular moving plantarly. Some people look at something called the position of the navicular tuberosity on the face line, but there's also the abduction of the forefoot, which is another component of pronation. But these things, you can have a pronated foot without having calcaneal valgus. It just depends on the dominance, the planal dominance from a podiatric perspective of the joints of the foot and ankle. And so depending on whether or not you have a component of pronation, for instance, in a pronated foot that has very little calcaneal valgus, of course, something to control the hindfoot in the AFO would probably not be too effective. That gets at the gist of what we're talking about here with regard to this algorithm. So just getting on to describe more about planal dominance, the Green proposed that planal dominance of the subtalar and the mid-tarsal joint axis influences this relative triplanar motion of the hindfoot, midfoot, and forefoot. And so if you carry on with a little bit more recent research, Beamers and others that have looked at the subtalar joint especially, which is getting better known from the biomechanics, then you know that not only the joint axis of these joints can vary from individual to individual, it can vary through the articular range of the joint. It also is more or less well constrained within a single patient. And so all of those things really need to be taken into account in the orthotic design. But for the purpose of this algorithm, we're very simply at just the orientation of those joint axes and how those things might feed into the type of movement of the hindfoot, midfoot, and forefoot in a posture which is pronated or supinated. Okay, so as I was saying a moment ago, that therefore certain supportive elements are acting on the hindfoot, midfoot, and forefoot, they may have greater or lesser direct or indirect influence over the forces on the anatomic structures and the joint alignment, and that's what we want to get at. We want to connect the clinical evaluation that observes these various components with the certain features within the orthotic design, which is designed to manage those things. So if you take a step back and you think about orthotic practice as an orthotist, you probably utilize a lot of different means in your orthotic designs to control the foot and ankle. Over the years, I won't say experimented, I've utilized, based on the evidence that was available to me, a number of different techniques to try and manage posture and manage patients. And some of them are on this list here, and I call them candidates. So there's the forefoot varus valgus wedge, metatarsal patter bar, 3-point midfoot abduction or adduction control. And I'm going to describe these in greater detail. There's the arch support, which is pretty common, and that may be elevated or relieved. Sometimes we're actually trying to, in a cavus foot, trying to actually lower the height of the arch. There's the sustantacular and taillight modification to control calcaneal valgus, and that was actually described in a publication by Marty Carlson some years ago. There's 3-point hindfoot inversion eversion control that was described by Savlich, and that some people call it a supramalleolar flare or a supramalleolar pad. If you want to look at it from the U.S. perspective of reimbursements, now 2275, that type of a feature in the orthosis. Excuse me. And then there is the medial or lateral intrinsic heel skive, and that was described and researched by a podiatrist named Kirby. There's the full foot inversion-eversion wedge. Inversion wedge, sometimes known as Blake inversion, another podiatrist. And then there is the sagittal ankle resistance to motion, resistance to plantar flexion and dorsiflexion, and the alignment. And this is very important. That's why I put 2 asterisks after it. And that is going to be the focus of the program on the 25th. I'm not going to talk about that today, just mentioning it because it is a supportive element within the orthosis, the AFO. Axial resist or patellar tendon bearing, a couple of means to unload the ankle by suspending the limb above the ankle. And then there's transverse plane control. There's this torsional control across the foot and ankle that was pioneered, I believe, by Oregon Orthotics, which actually is now Becker. But that type of transverse plane control in an attempt to control this triplanar motion of the foot and ankle. And lastly, there's orthotic joint alignment. So today, and with respect to what we're going to talk about, I'm going to talk about what's in red mostly. Forefoot varus valgus wedge, 3-point midfoot ABA deduction control, arch support, ST mod, and 3-point hindfoot control. I'm also going to talk about orthotic joint alignment. And in my practice, I've found that these are very basic areas of support to control posture, and have in my practice also, I've found them to be most effective in the management of patient. So I'm going to talk about these in a little bit greater detail so we can go into how they're evaluated and why they're used, and even a little bit how they're designed. So a forefoot varus wedge or a medial forefoot wedge, if you look at a patient in closed chain pronation, you can see the, if you can see my pointer, this middle picture here, in closed chain pronation, the forefoot is plantar grade and the hindfoot is pulled into valgus, okay? This may be due, the hindfoot valgus may be compensatory for a forefoot varus deformity. And that is seen in the open kinetic chain. Here's an actual patient, whereby you have a varus orientation of the forefoot. And now we measure the position in the coronal plane like this of the more distal segment, which is the forefoot, with respect to the more proximal segment, which is the hindfoot. And so you can see that there's a varus inclination of the forefoot with respect to the hindfoot. If there is a restriction of motion in the midfoot, it may be advantageous in an adult, usually not in a young pediatric foot. You don't want to necessarily manage with a forefoot wedge, but in an adult, it may be advantageous to sacrifice this alignment of the forefoot to gain advantage over a valgus hindfoot for the purpose of improving the alignment of the subtalar and other joints of the hindfoot. And so that is the notion there. In the AFO, it would look like this. You can see a little strip of red, which is thicker on the medial side than on the lateral side. Next is forefoot abduction control. And this is also a pronation control. It controls the component of pronation, which is midfoot abduction. Here's a free body diagram which shows these this 3-point pressure system along the shaft of the 5th metatarsal, along the lateral plantar lateral heel tubercle, and then an intermediate. And this intermediate portion comes from the medial portion of the medial longitudinal arch support. In order to implement this, the trimlines are very important. Now, whenever we design trimlines in an orthosis, we want to keep the center of pressure, which acts along the bones. We want to keep that center of pressure well within the trimlines of the orthosis. So a rule of thumb that we use is that on the medial side, we want the dorsal trimline to be along the dorsal aspect of the tarsal bones, and also the first metatarsal. And the termination of this trimline would be just proximal to the first metatarsal head. And the reason being that we really don't want to restrict the abduction of the forefoot. We want to restrict abduction of the forefoot. On the lateral side, similarly, we want the trimline to extend above or just proximal or dorsal, of the lateral border of the foot, so that it fully encompasses the axis of the fifth metatarsal and the tarsal bones, but it's a longer trimline which terminates typically at the lateral toe sulcus. And so the lateral forefoot is fully encapsulated here, so that that anterior portion of the pressure system, which is controlling the abduction, is contained, and you don't have this edge pressure, which makes a very high focal pressure because an edge has a very small bearing area. And so that's the typical design of that supportive element. The medial longitudinal arch support, Kogler actually had a beautiful paper where he and his team measured the plantar fascia strain as a function of medial longitudinal arch support. They got cadaver limbs and they instrumented the plantar fascia with strain gauges and measured the effect of wedges as well as arch support on plantar fascia strain, and saw a definite link between the two. If you look at, this is the free body diagram, by the way, for the medial longitudinal arch support. If you look at the anatomic boundaries for medial longitudinal arch support, we're trying to elevate the medial longitudinal arch, which is part of the medial column of the foot. And so the medial column of the foot is the first three metatarsals. So a medial longitudinal arch support should extend to about the third interdigital space so that it fully encompasses the medial column of the foot. If you extend it further, then actually in pronation and supination, you're actually trying to depress the lateral longitudinal arch, or the lateral column of the foot. And so you really don't want to extend that boundary past the third interdigital space, otherwise you're really fighting against yourself. So the anatomic boundaries for the medial longitudinal arch support, as I said, are to the third interdigital space, proximal, usually tapers proximal to the first metatarsal. And then also the apex of the pad is typically around the region plantar to the tarsal bone. In the AFO, it looks like this. The more plantar aspect of the arch pad or of the feature, this doesn't necessarily need to be a discrete pad. It could just be a modification in the structure of the orthosis where the shape of the orthosis is elevated. If it's more plantar to the foot, then it would have greater influence over the sagittal plane posture of the medial longitudinal arch. The sustantacular taillight modification this is a hindfoot feature, which is intended to reduce or resist hindfoot valgus. And as I was saying before, it was described by Marty Carlson. This supportive element actually is a force couple, whereby this is the medial side of the leg here. This flexure, by the way, in this free body diagram is representative of the subtalar joint. And so what we're trying to do here with this laterally directed arrow right here, this laterally directed force, is we're trying to increase the pressure just plantar to the sustantacular taillight, which is a feature on the calcaneus. And it provides in this view a clockwise moment, which is resisted by the counterclockwise moment, which is applied by a force directed medially at the distalateral tubercle of the heel. And so Carlson described this reduction as being located between the navicular tuberosity and the medial heel tubercle. And actually, this is one thing when I remember years ago when I was first learning how to design orthoses, it was unfortunate, but I had to actually, through reading, and I guess it's not unfortunate, it's just the nature of things, but I don't recall anyone ever explicitly telling me, like, what are the bony landmarks, where you locate this reduction. And so I tried all sorts of things, and some did work and some didn't work. But it's really kind of simply stated as do the reduction between the navicular tuberosity and the medial heel tubercle. And then the severity of the reduction is something that is in question. There appears to be, through some anecdotal studies, some diminishing return as the severity of that feature increases. For a very light, a very shallow, I guess you would call it, ST modification, you may not get as much control. If you don't have intimate contact between the non-weight bearing heel and the heel cup of the orthosis, I think you likely sacrifice control. If you think about that, if you have gapping in this picture here, if you have gapping so that there's no contact between the heel cup of the orthosis and the heel, then the heel can do what it wants until it actually takes up that pressure. And so an intimate fit between the heel cup and the heel, I think, is very important when designing this particular modification, if it's going to be effective. There's a certain amount of severity, I think, that, as I was saying a moment ago, there's a diminishing return. You can increase, and gain control, but then at a certain point, you don't gain more control, you just start gaining discomfort. And so the question is, how severe does this need to be, and how do you balance that against comfort? And this, in my practice, has proven to be a very effective means to control hindfoot valgus for me. It is the supramalleolar extension. Some people call it the Savage extension, and even draw a special trim line where the trim line just above the malleolus extends anteriorly. I want to point out a couple of features about implementation of this supportive element. Again, the 3-point pressure system. Here's an endpoint load. Here's an endpoint load. This is the tibia. This is the lateral heel tubercle again. And then there's this intermediate pressure, which if you look at it as from the perspective of a simply supported beam with 2 endpoint loads and an intermediate load, this intermediate load is actually the one that is applying the moment in order to try and reduce or resist the valgus. These 3 pressures have to actually act along the tibia and the fibula in order. They act along the axis of the bone, and so sometimes what I've seen, and I think we've all seen, is that the trim line of the orthosis is too close to the center of the bone, the axis of the bone. And if that's the case, you really lose the ability to apply this intermediate pressure. A rule of thumb that we use is that the pad should be as far anterior as it is posterior. That way the center of pressure for this intermediate load lies in the center of the pad, and it occurs right along the axis of the bone. It must be fully encompassed. The other thing is that the maximum bending moment, this is from mechanical engineering, the maximum bending moment of a beam in 3-point bending occurs at the point of action of the intermediate load. And so I would ideally like for that point of action to be at what I'm trying to bend, which would be the subtalar joint typically. But in practice, you can't really do that. If you attempt to apply that intermediate load, that pressure at the subtalar, it really is not too effective. If you try and apply it directly over the medial malleolus, it also is not typically tolerable to the patient. And so what we will typically do is apply that pad load as close as possible, just proximal to the medial malleolus over a broad area. But sometimes what you'll see is this pad is way up here. And if you do that, then what you're doing is actually reducing the bending moment on the structure that you're trying to affect a postural change or resist a postural change or take a stress off of a structure. And so you want to try and keep that pad load as close as possible to the medial malleolus when it's implemented. So I've talked about a number of different supportive elements. One thing that I want to mention with this slide is, okay, we've got a number of different supportive elements. How do those things work together directly or indirectly to provide the same type of resistance to pronation? So this is actually my daughter. A couple of years ago, we actually did this little experiment where we took an air bladder, which looks like this. You can pump it up there, it's inflated, here it's deflated. And we put that air bladder at the supramalleolar in the location where a supramalleolar pad would be located, just proximal to the medial malleolus, right here is where it's located in the video. And then we put a FlexiForce sensor, pressure sensor, underneath the arch pad in the AFO so we can measure the arch pad, or the arch pressure, excuse me, as she internally and externally rotated her right foot. So what she's doing here is she externally rotating, internally rotating. You see she's rotating her hips back and forth. And what she's doing is she's selectively supinating and pronating her foot, right, by that rotation. And we're measuring the pressure that is occurring at the arch pad here while she's doing that. So this is the pressure. It's increasing, decreasing, increasing, decreasing as she internally and externally rotates. So we measured the arch pressure with the pad inflated. And then let me go back here again. So here's the pressure, increasing, decreasing, increasing, increasing is down, by the way. decreasing, increasing, decreasing. And then I go in and I deflate the bladder, okay? I'm pushing a little button there, lets the air out of the bladder, deflates it. So I reduce the supramalleolar support, and then she does the same thing. Pronate, supinate, pronate, supinate. And so the pressure, when we deflated the bladder, the pressure underneath the arch for the same movement actually increased. And so what this says is, it's a demonstration of how arch support and supramalleolar support can help to reinforce one another. If I have too much pressure at the supramalleolar pad, I could potentially increase the height of the arch pad in order to decrease that supramalleolar pressure, and vice versa. So what this says is, it's just a visual demonstration of what I think probably most, if not all, orthotists know, and that is you have to get the balance of these forces and these pressures right in order to make a tolerable device that works well. And sometimes one of the things that we're doing a lot in fitting the device is trying to substitute or reinforce a postural control with another one that might be indirectly linked through the biomechanics of the foot. Okay, so all of that has to do with valgus, and now I'm going to do the same thing a little bit more briefly with regard to a varus foot. And so with regard to a varus foot, oftentimes if there is a forefoot postural abnormality associated with a hindfoot varus, it would be a forefoot valgus typically. And you've probably seen this in stroke patients. This is a varus foot actually where the forefoot and the hindfoot are actually aligned in open chain. This is a varus foot whereby the forefoot is actually, you can see the forefoot valgus, which is associated with that. And here in weight bearing with the forefoot plantar grade, you can see the hindfoot in varus. And so in closed chain, sometimes you can have a compensatory hindfoot varus for a forefoot valgus issue. Coleman described how to determine that clinically with what's called a Coleman block test you're undoubtedly familiar with, whereby you look at a hindfoot varus inclination, and in order to determine whether or not it is compensatory for a forefoot valgus, you post the lateral forefoot and see if the hindfoot varus resolves. If it does, then perhaps a forefoot valgus wedge or a lateral forefoot wedge might be an effective supportive element in the orthosis to help control the hindfoot. Again, the more proximal position, the hindfoot, is prioritized over the more distal, the forefoot. With regard to Trimlines to resist the foot adduction. So this is 3-point bending, just opposite to what we said before for valgus, where we have the forefoot attempting or trying to abduct with the pronated posture. With the supinated posture, sometimes we have an adducted forefoot. And so this is the same, but different. It's forefoot adduction and 3-point beam bending, simply supported beam in the transverse plane with these pressures intended to resist that adduction. The intermediate force is a little bit more challenging to apply. Typically in the design of my orthoses, what I'll do is extend the trim line on the lateral side of the foot about 10 millimeters distal to the tarsometatarsal joint, 5th tarsometatarsal joint, and I put a pad there so that this actually goes to 0 as you move toward the trim line. The pressure does, but you get this focal pressure at the tarsometatarsal joint or in that region on the lateral side of the foot. On the medial side, you can either encompass the first metatarsal only or extend distal to the halix. And sometimes, especially in infants trying to control a club foot, not in infants, but in older kids where you're managing with an AFO after the Dennis Brown splint has been removed, sometimes we try to utilize as much bearing area as we can, which is the great toe as well as the first metatarsal head for that. Here's what it looks like, these 3 points in the orthosis in blue. And with regard to another supportive element in a supinated foot, we still use, as we all know, the medial longitudinal arch support, and that may be for two reasons. So it may be actually oftentimes the cavus foot is a more rigid foot, and sometimes it's painful in the plantar fascia, and we actually want to provide support there, even though the arch is elevated, to reduce that pain, to load share, to take some of the force off of those structures. Sometimes actually, and this is equally as valid, sometimes we actually want to reduce the feature. So I'm showing a medial longitudinal arch support, but that might actually imply that we're going to reduce the height, or do arch fill, that we call it on the positive model, to reduce the support underneath the medial longitudinal arch, so that we, through other means, let's say with a lateral supramalleolar push, we can try and lower the height of the medial longitudinal arch to prevent progression, maybe like in a CMT or something, if we're trying to prevent progression of that cavus foot posture. Again, the boundaries of the medial longitudinal arch support would be the same as in managing pronation. And again, the boundaries of the three-point pressure system, this time acting along the fibula on the lateral ankle, just proximal to the lateral malleolus. It should be centered along the axis of the fibula. The distal endpoint load here, this one right here. The distal endpoint load is located along the medial heel tubercle, which could be blended into something just plantar to the sustantacular taillight, also on the calcaneus. Okay, so I've gone over, with regard to the supportive elements that the algorithm is focused on. I've gone over what those elements are for controlling a pronated and a supinated posture. And I want to mention one more thing before I present the actual algorithm, and that is the orientation of the orthotic axis, or the alignment of the orthotic axis as relates to the anatomic axis. In order to show that, I have two images here. One is, this is a shoe, and this line right here is the knee axis. The knee axis. And if you draw a line between what's called the malleolar axis, which is the axis of the talocrural or the talotibial joint, it's typically externally rotated about 25 degrees. That's typical. And so if I align the ankle axis with the transmalleolar axis, and with that 20-degree external, 25-degree external rotation, then I have what we call, in our terminology, an anatomical alignment. The ankle axis is anatomically aligned in the transverse plane with the ankle axis. But there's certain consequences to doing that. Lanais, back in the 50s, said that you should do that. He didn't say anything about other alignments, but he did say something about that. And this is an interesting survey question. A lot of the orthotists that I know don't actually align with the transmalleolar axis, but rather they align with what we call a mechanically aligned ankle axis, and that is with the ankle axis aligned parallel with the knee axis in the transverse plane. And so I guess you have to ask, why would you want to do that, and what are the consequences of that? I have a little bit of an image here shows what happens. So I'm going to first have a simulation here of an ankle axis in an AFO, which is aligned with the transmalleolar axis. In the transverse plane, it's externally rotated about 25 degrees, but also this is the coronal plane, looking at the AFO from the posterior aspect, it's tilted, because the average tilt of a transmalleolar axis is about 8 degrees, that's the mean, out of the transverse plane. So what are the consequences of having this triplanar axis? I'm going to run that again. The consequence is that you have triplanar motion of the foot plate with respect to the tibia. Now, of course, the foot plate is in the shoe, and the shoe is planted on the floor. And so what really happens, I think, is you get this pressure distribution, which is moving dynamically in the tibial section. But as the ankle dorsiflexes, you can see from this view, the ankle is dorsiflexing, you get abduction and eversion of the foot plate. Those motions are coupled. if you have a triplanar axis like that. Now, you may or may not want that. If you do that, it will track the motion of the foot very well, and you'll get less shear, let's say, in the tibial section. But you'll also get a movement which lacks the compensations of what the foot would normally do if it was free to move. The mid-tarsus and the forefoot was free to move, which it is not in the orthosis. Those joints are relatively constrained, and so we're trying to distill out all of that combined motion into a single axis, into a single joint motion that may or may not be beneficial up the kinetic chain to have a foot plate or a pressure moving that way on a tibia as the patient walks. When we mechanically align, here you see the red, we have the joint axis in the transverse plane, and we have no accommodation for the transmalleolar axis. This is aligned with the knee axis. What we create here is a much more pure sagittal plane movement. Now, one of the things about this type of mechanical alignment is that it's non-accommodative of calcaneal valgus and dorsiflexion, which is one reason why I think that I have a tendency to gravitate toward it when I'm managing my patients who pronate, because I don't really want to accommodate necessarily that calcaneal eversion with dorsiflexion. I'm trying to resist it in a lot of the different supportive elements within the orthotic contour. Why would I then accommodate it dynamically by allowing the calcaneus to evert with dorsiflexion? And so that's the rationale behind using a mechanical alignment. That said, if there's an extreme amount of tibial torsion, if you align the transmalleolar axis 30, I've seen 50, 60 degrees of external rotation, I think you, at least in my experience, you have to be partially accommodative of that orientation. If you aren't, then it's very difficult to adjust the orthosis so it's tolerable, because it's really fighting as dorsiflexion occurs. It will really fight the motion of the talotibial joint. So I think that there has to be some compromise there. Okay, with all of that being said, now I'd like to present the algorithm. So this is a recipe to put all of those things together, and it is in the form of a colorful thing. The selection of orthotic supportive elements is in the colorful section on top, and that has to do with identifying whether or not the posture is tending toward pronation, or whether it, now I should clarify that there may not be a postural abnormality, there just may be an abnormal stress that is in a structure that is intended to be resisted here. Think about an ankle sprain, right? It may not lead to a postural abnormality, but I want to take the tension off of the lateral ligaments of the ankle, let's say. And so it can be looked at in that way as well. But with regard to the simplicity of the algorithm, we do use a simple analysis using the foot posture index to get into the pronation or the supination side. The pronation side of the algorithm being here in red, and the supination side being in blue. And there's a decision box in the middle here, which takes you along one or the other path, depending on that assessment. The second block of the algorithm has to do with AFO style, whether or not it's a high stiffness, non-articulated, articulated, or leaf spring. And again, this is a topic for the 25th, not for today. And then this last section has to do with ankle axis alignment. And I am going to talk about that today in conjunction with this, because it has to do with, I think these two things can go together in posture management. So again, we had that whole list of candidate supportive elements within the orthosis. And as I said, I've sort of selected out ones that I thought were in my practice, the evolution of my practice. I've not gotten too fancy. I'm using more of a chainsaw than a micrometer, so to speak. I know that I'm not referring to the same thing, but just the idea that orthotics, sometimes we need to have the most grossly influential attributes in these devices, I think, in order to really have something that's substantively visual and impactful for the patient. At least that's my experience. So on the red side, again, these are supportive elements which have to do with managing various aspects of pronation. This first red block is, you can see, hindfoot elements. So these blocks here are midfoot elements with arch support, 3-point bending, resisting abduction, and this is the forefoot. And over here on the supination side, similar. On the bottom block, we have the ankle axis alignment, and that has to do with whether or not there's a typical alignment to the transmalleolar axis, and deciding whether or not to use a mechanical or an anatomic alignment. So in order to talk about the details of this algorithm and its application, I'm going to give a case example, a simple example. So there's a little girl, a 4-year-old girl with sacral level myelomenimbocele. And with that, of course, she has profound plantar flexion, weak, actually absent plantar flexion, with other motor function preserved, though, largely. Her internal tibial torsion presents, as you can see here. She has internal tibial torsion, but with moderate fibular shortening, not too profound, and also posteriorly displaced lateral malleolus, which was kind of confounding with respect to that. And I think between the two, actually, it ended up putting her transmalleolar axis and in a pretty typical orientation. Her foot posture was calcaneal valgus with coronal plane dominance, and so a lot of hindfoot involved in her pronation. And some of that, most of that, did not appear to be coming from the shortening of the fibula. And there's midfoot pronation as well. So there's abduction in the midfoot, and also she was insensate. This is what she looks like trying to jump. Of course, she has no plantar flexors, and she tends toward excessive dorsiflexion, which causes her to walk in knee flexion throughout stance phase. So she's not ever achieving really full knee extension, which is you would expect energy consumptive. She also has poor foot positioning at initial contact, excessive dorsiflexion at initial contact, and as you would expect, a late heel rise in terminal stance and no push off. So in her original AFOs, a good attempt was made, but you can tell that a lot of things were added to this in an attempt to manage her, to select the right supportive elements in order to manage her tolerably. The AFOs are solid, and because of a lot of things in here, like padding and things in the orthotic shell, they were quite oversized, which required a much larger shoe than was necessary if a more intimate fitting orthosis was provided. Full foot and tibial section AFO foam liners, so they were trying to reduce irritation again by providing abrasion resistance and cushioning. There was the addition of a high elevation arch pad, but you might question how effective an arch pad would be without plantar flexors. It has a tendency just to really kind of dorsiflex her into the upper of the shoe, because she really has unrestricted dorsiflexion, and so trying to use that element to control her hindfoot is really, you wouldn't expect to be very effective. A valgus control strap was added, and also an attempt to control the hindfoot. And a couple of things here that we need to look at as far as implementation of these supportive elements. First of all, the gapping here. See this circle right here shows the gapping in the heel cup. So there was a great deal of gapping between her heel and the inside of the orthosis, in addition to the padding being added, which further increased the clearance between the heels. So very little control for an ST modification was available there. And the other gapping here, you can see just proximal to the medial malleolus. And so the result of that was basically a lot of navicular shear and pressure and callousing there, and some other things here, which actually had to do with just clearance of the externally rotated ankle mortise, with her fibula being very far posterior. She had a lot of callousing there. Distal lateral calcaneus also had some irritation, and I think that also was due to her basically pronating her valgus in her hindfoot being uncontrolled. And so all of that was occurring in the orthosis and somewhat challenging for this orthosis to manage. So what are the goals of revising this design? Of course, we want to improve the postural control of the orthosis to reduce the hindfoot valgus, which is a principal postural abnormality in this child. We want to, with the goal of decreasing skin irritation, to improve the fit of the shoes as well. Shoes are very important in optimizing gait function with the control of sagittal plane motion. And so we need a well-fitting and supportive shoe in order to do the things we really want to get to, which is to help her extend her knees fully in the orthotic design. But for today, we have to first get her tolerably braced and decrease the skin irritation and callus formation. And we want to provide active resistant dorsiflexion. So our goal here, we need to do all of that in order to really be able to do what we really want to do, which is to provide active ankle motion. We want to let her ankle move. We want to move away from a solid AFO and preserve her first rocker and her second rocker in gait if we can. Now, when we do that, of course, in a pronated foot and ankle posture, especially in a hind foot pronation, we're going to be challenged even further to control her posture, because as the foot pronates, it everts, and as the foot dorsiflexes, it everts and pronates. And so it's probably easiest to manage that posture tolerably in a solid, but we have an ambitious goal. We not only want to improve the postural control in the orthosis, but we want to do so with an articulated brace, because we want to get to an articulated brace to help improve her gait function. So here's the algorithm, and we're going to follow this through now in order to select the postural support elements which we think would be effective for the patient. She has a foot posture index greater than 2, and if you look at her plane of dominance, she is coronal plane dominant, and so she has primarily calcaneal valgus. Also, she has, as I mentioned, she has 0 plantar flexors, and so an arch support is not going to be as effective. But first of all, this foot posture index being positive and highly so gets us into the pronation side of the algorithm. Hind foot valgus greater than 5 degrees, yes. So that means that since we have an abnormal hind foot valgus, and we know it's a principal goal of the management, we want to have the hind foot support from the medial supramalleolar extension and from the ST support. So both of those supportive elements are identified, and we want to make sure that we implement those well. Now we're going to go on and identify her forefoot, any postural abnormalities in the forefoot. Does she have a forefoot varus in open chain? No, she did not. Actually had a very flexible foot in open chain. And so that leads us down to the question of, does she have excessive medial longitudinal arch height? She does, and depression of the medial longitudinal arch in closed chain. She does. She also has a midfoot abduction, which was much more obvious, and so she has a midfoot pronation as well, and a lot of abduction of the forefoot with that pronation. So that is so, and so what we want to do is we want to include that medial longitudinal arch support, again knowing that it will not be a principal supportive element, and so we're going to have full arch support as tolerated and as cast, but not really expect too much of it to help us control the higher priority hind foot posture. And then we're going to also include pronation control trimlines. So we're going to try and contain in 3-point bending and prevent the forefoot from abducting. So those are the basic supportive elements. This is what it looks like in the cartoon with regard to what those are included, and there will be no forefoot medial wedge because it's not necessary. In the articulated orthosis, these are the locations of those supportive elements. And as I mentioned, the hind foot elements, which are primary, expected to be most effective to manage the principal postural deficit of hind foot valgus, which is the medial supramalleolar support and the ST support. Midfoot elements, the pronation trimlines are expected to be effective, but not really the medial longitudinal arch support, so it's included. and there are no forefoot elements included. With regard to the ankle axis alignment, we look at it and consider whether the transmalleolar axis was greater than 25 degrees external rotation, and it was not. And so we selected a mechanically aligned orthotic ankle joint axis, which is defined by our definition as being perpendicular to the long axis of the foot, which is relatively neutrally aligned in normals with the line of progression. Now, of course, she has an internal foot progression angle, and so that's something that needs to be considered. But with regard to this, it has to do with the articulation of the ankle joint with respect of the tibia with respect to the foot. So here's the outcome. When it comes to the intimacy of the fit in areas where we felt was most important to have that intimate fit, the original AFOs are on the left. And you can see the supramalleolar pad, which is gapping, so there is no real contact in a place where we felt it important to actually apply that intermediate pressure to resist the calcaneal valgus. The other thing is, if you look here, you can see that this trim line is just shy of the axis of the tibia, and so it's a little bit difficult to utilize that to actually resist that calcaneal valgus. On the new orthosis, we have a much more intimate fit, which was accentuated by a pad just proximal to the medial malleolus in order to resist that calcaneal valgus directly. With regard to the ST modification, another mod which is intended to resist calcaneal valgus, in the original orthosis where they had added the valgus control strap, and of course we had this gapping, you can see in the new orthosis we have an intimate fit between the non-weight bearing heel and the heel cup of the orthosis. So in implementing this, what I typically do is I will, I want the width of the heel cup to be the same as the uncompressed width of the non-weight bearing heel. That's my starting point. And so when I do my fittings, I actually check to make sure that that is my starting point. And so this was actually confirming that I had that intimate feel of the hip, intimate fit of the heel cup, so that I could be reasonably assured that my ST modification was effective in helping to reduce or limit that calcaneal valgus. So on follow-up, a few weeks later, we know that the fit of the shoes was improved with the reduction in shoe size necessary to accommodate the AFO. So that was good. We were able to get a much more appropriately fitting and supportive shoe for the patient because of the more intimate fit of the orthosis. There's no padding, as you notice, inside it. So actually, we've taken an orthosis which originally had padding and removed the padding, but actually improved the comfort and reduced the irritation from the orthosis in that way. Secondly, the effectiveness of the pronation control appears improved, and we cite as evidence of that the decreased medial malleolar drift in mid-stance. So if you want to look at whether or not you're controlling a calcaneal valgus, watch the patient walk, and in mid-stance, meter with your eye, or with a video and your eye, meter the amount of medial drift, the movement medially of the medial malleolus. And so that's an observation that you can make dynamically. The other thing that you can look at is the step width variation, which is actually through research been shown to be indicative of lateral balance, and then overall improvements in gross ambulatory pattern. So we're looking at the whole patient when she walks, and that appeared to be improved. And then directly at the foot and ankle, we have the decrease in irritation. So less redness, less rubor, and also resolved callus. So if you just want to take it at the end of the day, we actually were able to resolve the callus at the navicular and the lateral malleolus after several weeks in the new orthosis. And again, I think what should be pointed out is that we went from a padded to a non-padded orthosis. We went from an orthosis that had adjustability and valgus control with one that was static, and yet we actually improved the support of the orthosis and reduced the irritation of the orthosis on the skin and the limb. So that was the overall goal. So that is it. That is the presentation of the algorithm. I'd be happy to provide a copy of that. If you want to email me, there's my email address, mccurcy@beckorthopedic.net. And again, I thank you very much for your kind attention, and I hope everyone has a good day and evening.